Yes, go live now. Yes, go live now.
On YouTube as well?
On YouTube and Facebook now.
Is it listed as well?
It's listed as public.
Is it really live? I can't see it on the YouTube.
It's on the live now. I'm sure it's on live. And the link is the same. Then haven't been changed.
The live link, right?
Yeah.
On the stream, there's sound coming. Can you mute that? Is it your mic?
No. hi, Dr. Khan. Yeah, are you able to hear me? Yeah. We can hear me. No sound from him now. Oh, his sounds will pop up when we do the transition. So we are no longer hear him when we are like getting ready for that. So whenever we are ready to transition him, we are yeah.
Hamza bhai, can we have Fatima in and start?
Yes, sir. I can hear you. I'm just talking to Dr. Fatima right now. I forwarded her the link.
Wonderful.
She's joining.
Okay, cool.
Yeah.
And then we can start, right? I think because I'm in the stream right now. I see that
Yeah.
few
You
few.
can start talking if the audience is there. You can just start communicating. You can start telling them what's the show about and stuff like that.
Oh, come on, we'll do it in a. Welcome, Dr. Fatma. How are you? Good, good. Screen share, go, and we're good to go. We're going to try this today a little bit differently.
One second.
The other little thing that you could do if you want, don't have to, is well, set up your screen share first. I think that would be
Okay.
important. Let's just
Sir,
let's
then let me know when, like, you can see the screen.
okay. Yep, it's good to go.
Okay, sir. So I have to start from, sir, asthma management or like from the types of asthma?
If you go, so let me say this: if you you'll do the management part.
So all I can skip is the diagnosis, differential diagnosis.
We done that last week, so we'll do the next bit. Okay.
Okay. And sir, do I need to give some overview like of asthma definition or just skip all and directly go to asthma management?
You can. I think we've done that, so we'll.
Okay.
Okay, I don't know if everyone can hear us. If you can, just put in a text there so we can proceed with this. It's already 3 o'clock. So can you hear? Can you hear us? Okay, Fatma. Just note that there is a little bit of a lag, and so we'll just start. I think that's the important thing. We just start and see how it goes. Um, this is all amongst our colleagues and stuff. So
Okay,
one,
sir.
two, three. Let me bring this up. So thank you everyone for joining the presentation today. Basically, we're just trying to do continue the series that we have done in the past few shows. So I'm Dr. Khan. Today we're going to have Dr. Fatma back again, and Dr. Fatma is going to be talking about the further management of asthma. Last week, just to recap, Dr. Fatma is a currently resides in Islamabad, Pakistan. She is a graduate from um,
Hamdard University, Karachi.
that's your right, Hamdard University, Karachi. And she has got a distinction as well in part one, right, Fatma? That's
Yes, sir.
very nice.
Yes, sir.
That's very nice. And then she's attended. She's licensed to practice in Pakistan, of course. And she did our initial presentation last week about the diagnosis of asthma for you guys. We recapped how is it relevant in a daily on a daily basis for everyone. So what we'll do today, we'll go on to discuss a little bit about management of asthma. All right. Now the second part I want to say, since we want to continue the same theme, the aim of this presentation and the show is your active participation. We want you to be able to uh, com- uh, communicate, and so periodically keep on looking at your YouTube chat, and we will be putting in questions. And I see all of you there. And so I'll be taking some of the questions in between, and then most of them at the end. So please put your questions here. All right, that's very, very important. Okay, so I'm just gonna say
Hello everyone, this is Dr. Fatima. As we have already discussed asthma overview, its pathophysiology, its type in the first episode, and today we will talk about some asthma management. So, what are the basic goals for asthma management? So, basic goals for asthma management is to achieve and maintain control of symptoms, to prevent asthma exacerbation, to maintain pulmonary function as close to normal as possible, avoid adverse effect from asthma medications, and prevent asthma mortality. So, what are the main points for asthma management? So, first of
so.
all,
So so Fatma, your slides are not transitioning. So see if you can transition.
sir,
No,
now.
we can see it now. We can see it now. Okay, keep going. Good.
Okay. Okay, so regarding asthma management, these are the main points regarding asthma management. First of all, is lifestyle modification, medications, oxygen therapy, pulmonary rehabilitation, and the advanced treatment that is bronchial thermoplasty. So, what is lifestyle modification? So, lifestyle modification basically plays an important or significant role in managing asthma by helping to reduce the triggers and improve overall health. As I have already perfume, strong odors, molds, pets, etc. So that can benefits with individuals with asthma, and like you also by maintaining healthy weight, by regular exercise, by quitting smoking and managing. Next is about the medications. I will discuss about the medications in detail in our next slides. Next is oxygen therapy. So oxygen therapy is typically a primary treatment for asthma, but it can be used in certain stimulation like you can say or status as medical. Next is pulmonary rehabilitation. So, pulmonary rehabilitation is a comprehensive program designed to improve physical, emotional, and mental health of individuals with chronic respiratory conditions like COPD, asthma, or other respiratory conditions. So, the key components of pulmonary rehabilitation are exercise training, to educate people regarding this, counseling, smoking cessation. So these are the main points in the pulmonary rehabilitation. Next we have is advanced treatment, which include the bronchial thermoplasty. So I will discuss little about the advanced treatment in my next slides. So first is medical management. So medical management plays an important role in management of asthma. So medication for asthma come in several forms, that is inhalers, nebulizers, and pills. And we can divide the medication in two major categories that are so quick relief medications. So quick relief medications you can say are temporary inhalers, also known as rescue inhalers or relief inhalers. These are the medication used to provide immediate relief from asthma symptoms or acute exacerbations. These inhalers typically contain short-acting beta agonists, which are SABAs, as the active ingredient. So the main ingredient, or you can say a main drug used in the temporary inhaler is albuterol or salbutamol. So how temporary inhaler works? So they basically work by quickly relaxing the muscles surrounding the airways, which help to open them up and alleviate symptoms such as wheezing, coughing, shortness of breath, and chest tightness. As you all know, asthma is basically you can say a constriction or inflammation and narrowing of the airways. So what temporary inhaler do? They quickly relax the muscles.
So, Fatma, just one second. I'm just looking at the main presentation right now. For some reason, your slides are not moving there, and I know you got a lot of slides. It's still stuck on the first asthma slide. So this may be a little bit of a glitch. So let's do this. While we go along, we will have a chat in the group. So, and I understand you have to adjust the lifestyle modification is very important. And oh yeah, now I see it. Now it's popped up as Fatima's now as we can see. So I'm just gonna ask, can you see slides? Can you see slides moving? And so it is moving now, and I see all of it all of a sudden has gone through. And
Okay.
it's now on introduction asthma is a chronic inflammatory, and they're saying they can. Okay, so wonderful. Maybe it's on my screen, then it's a little bit of a jet. It's a little bit of a lag. Let's just keep on then moving along. I must say I want to emphasize one little point here, which is very under appreciated. The starting point, the starting point for treatment of asthma is, what do we think is the starting point of treating of asthma? Well, let me ask first the audience. All right, I will put that question out there, and we have quite a lot of our team members on this. So where would you start from educating? Um, where would you start from treating asthma? And the and then I'll put the answer for this one in so that we can all. But then is education. All right. Understanding asthma. Yes, correct. I know there is lifestyle modification, there is avoidance, there is triggers, but the key is if you understand what asthma is, then you will be able to tackle the disease itself. All right. And that's the key. Anyone in the family member has who has asthma has to know what is asthma, how it starts, and how I control it. That's the starting point. Does that make sense, Fatma?
Yes, sir.
Yeah, that's the key. So let me ask you a question. I know we've covered quite a lot already. If you're young, or it could be when you're in an older age, right?
Yes, sir.
Both need to have asthma addressed in one form or the other. So how would you address educating an adult versus a kid, which will in this case kids or pediatrics. So let's start with first kids. How would you educate a kid saying you have asthma? What are you gonna do? What are the sort of like the first few? This is all about what you before we go to tell them more stuff, right? Um, what would you think is the key thing that we tell them? A kid, for example, that you have asthma and you want to educate. Where would you start from? Would you would you tell would we tell them, oh, the pathophysiology is this, or where what? It's hard, right? You can't tell kids that they won't understand. So where do you think what would be a practical step for the kids to start from? Would you?
To educate parents first.
Very good, Gal. I think that's fantastic. Yes, doctor. You before we go on to discuss taking history, doing side effects, or anything, you have to have this conversation for the with when it's the kids with the parents. It's impossible to treat if you don't have the kids involved in it. So I'll strongly encourage. Please do put in your comments. It's okay. This is all going to be edited again, and you don't have to worry. But I want you to put your comments in so we can get an idea. You have to you have to educate the parents. You have to have the first conversation with the parents before you go on to have the conversation with the kids. So let's give a rough ballpark mark. Kids could be as young as 2, 3, 4, not understanding anything at all, to 6, 7, 8, 9, 10, and then teenagers, but they're not going to listen to anything anyways when you have teenagers, right? And then older group. So where would be a good starting point be when you're having a conversation with kids? Let's see what our audience would think. A starting point where and it's actually for everyone. Where would you be having a starting point in a if any of you have this, it's very important that you try to explain. What would you try to explain to a kid? Because they all experience. Some of the kids know when they become short of breath, they know they struggle. They know parents are worried and they're going to have to take us to the hospital and stuff like that. And yes, we tell them what happens. They already know about it. Kids especially suss it out. But what they do, which adults do as well, is they ignore a lot of times symptoms. So it's very hard, even though they may be wheezing, they're not going to tell you, Dad, I'm wheezing, or Mom, I'm wheezing. So what are you going to do? How are you going to start? Say you're a parent, and so you talk about this to let them be aware of this. Explain what asthma is in simpler terms, which is true. We absolutely got to do that. You got to tell them what's going to happen. What else? Yeah, go on. Akif, tell us what else. Quite a few of you are watching. You should be able to put a comment in. I'm sure you all have seen good care. I think that's very great. I think talking about the first step is talking about the trigger. Some of you are so smart, so brilliant. Very good. You should be starting off by talking about triggers. I think using the medication comes as a second step. Absolutely important. They but the first thing is you ask, oh, did you go near a blah blah thing today? Or they come and they will never tell you themselves a lot of times, but knowing that they're mindful about what can trigger their asthma is very, very important. Strong bond with the kids, and absolutely that's very important. If you don't have a connection with the kids, then it's going to be a struggle for everyone. So yes, absolutely right. But educating them, if they are at the age, about the trigger is very important too. Okay, sometimes we know that we are exposed. They may be subtly wheezing. They may say, oh, mom, I'm fine. Don't worry about." How would you know that this is an asthma that I need to start worrying about? Is it someone said very nicely that, oh, they should know, they should keep their inhalers on them all the time, whatever regimen you're going to go with, keep the inhalers. And yes, by the way, do keep a spare inhaler, uh, a spare inhaler with you. If they don't have it, they should have, but the spare inhalers should be accessible. The inhalers, you should know about the expiration date, blah blah blah. All of that is very good. But what would be another question? You say, okay, what is it, another important tool that you can use? By the way, there is something called an asthma action plan that everyone if you have action, you should say, hey parents, this is what you should keep around. And that has sort of like got a guideline on number of things that are on it. And I think Dr. Fatima may or may not cover that. She's going to talk about the inhalers. But before we could talk about that and the action plan, the question we really words answer after the triggers: what is a simple tool that you could use a lot of times? It's age dependent as well. Some kids may not be able to use. And so what would be a simplest tool that you can use that could gauge? Um, and I think we've touched on this before, guys. We don't have an assessment form today, but I would love to hear from you guys what you think. Yeah, absolutely. I, I yeah, and I'm saying inhalers, and I hear M is saying a peak flow meter. Yes, nebulizers. All of these are important, but a cheap, simple way of gauging, is the asthma mild or is it start having problems, is knowing what a peak flow meter, you have that, and know your value, know the value. Very good. I see that. Yeah, Manaza is right too. You have to have your inhalers for sure, and they have to know how to use them when the age comes. They will know. They pick up fast, right? So, and those are our questions. Those are our questions. So, knowing about your peak flow, and Dr. Fatma, could you tell us a little bit about that? I know you're going to go on. What is a peak flow meter, if you have that, and you could share that slide for our audience or our team? I would say the team and everyone.
Sir, I don't have a proper slide, but in peak flow meter, like there is a device, like this test can be done in home as well. So basically, this is a device in which like person is like inhale it and exhale forcefully as he can, like by his full force.
Absolutely. And then if you are having an exacerbation, generally peak flows can vary throughout the day. Sometimes in the mornings you can have a stronger peak flow. Later in the afternoon, the value can be less. But just know that um, it can vary throughout the day, but you should not fall below a certain threshold. And if you are falling below your 20-30% decrease, you should get alert that, oh, there is something going on and we have to treat this a little bit more aggressively. All right, so I'll let you go on. There's were a few questions that have popped up, and I think in the assessment part, that's brilliant. Someone's put those questions up as
Yes, sir. I have already posted in the group as well, the assessment form.
okay. Okay, perfect. Okay, so please continue. Let's do the next bit. When child runs out of breath while doing simple activities, is absolutely an indicator that they may have an asthma event going on. The asthma may be getting worse. See, the airway starts getting constricted. And what did we say last time? One of the things you may hear a lot, you could hear, is that they start to what do they start to do is if their airway starts getting constricted,
Constricted,
what happens? The symptom that they have is,
wheezing.
yes, absolutely. So please, and that was discussed a lot last time. They wheeze. So please don't forget that. Okay, the doctor from the please continue. Let's do the next bit. Absolutely, they become short of breath. That's right. Jana is saying she's short, but I want you all to understand what is the wheezing part in this. All right, Jana, please continue. Sorry, Doctor Fatima.
Okay. So, as we have discussed, that temporary inhalers provide a quick relief from asthma symptoms, but they should be, you can say, complemented with long term control medication for effective asthma management. So, the long term control medications we have is inhaled corticosteroids. So, inhaled corticosteroids are the most effective and commonly prescribed medications for long term asthma control. So, how they work? So, they work by reducing the inflammation in the airways, by decreasing the mucus production and airway hypersensitivity. So, the main example of inhaled corticosteroids are beclomethasone, budesonide, fluticasone, and mometasone. And ICS are typically used as maintenance therapy as well and are available in various inhaler devices, for example, meter dose inhalers and dry powder inhalers. And ICS is also considered as, you can say, a first line treatment for the asthma.
Okay, so that brings up a very good question. Uh, you have a couple of more slides on this, Doctor Fatma.
Yes, sir.
Okay, why don't we do this section, then we'll talk more
Okay.
about inhalers and nebulizers first. Okay.
Okay.
Sure.
So next is long-acting beta agonists, which are LABAs. So LABAs are basically bronchodilators that work by relaxing the smooth muscles around the airways, making it easier to breathe. And LABAs are mostly, or you can say often used in combination with ICS to provide additional bronchodilation and improve asthma control. And examples of LABAs are salmeterol and formoterol. And LABA should never be used as monotherapy for asthma and they should always be combined with ICS. Next, we have our combination inhalers. So, as the name indicates, they are the combination of ICS, which are inhaled corticosteroids, and LABAs in a single device, making them convenient for long term asthma management. So examples of combination inhalers are fluticasone and salmeterol. So fluticasone is ICS and salmeterol is LABA, and which comes under the brand of Advair. And next we have the combination of budesonide and formoterol. In this, budesonide is ICS and formoterol is LABA, and it comes the under name of Symbicort. Next, we have is leukotriene receptor antagonist. So these medications work by blocking the action of leukotriene, as the name indicates that the leukotriene antagonist. So what are leukotrienes? They are the chemicals in the body that contribute to inflammation and constriction of the airways. And the examples work. They work by preventing the release of inflammatory substances such as histamine from mast cells and by reducing the airway inflammation and hyperreactivity. And example is promoline sodium. And last we have is biologic response modifier. So basically they are used in severe asthma. In severe asthma treatment, these drugs target particular protein or cells involved in inflammation. Examples are omalizumab, vipolizumab, and dupilumab. So I will not go in as much detail of all these drugs. So only thing you have to remember is like where these drugs action. So omalizumab basically acts on the IgE, like it combines with a free IgE, and which causing the like less free IgE in the body, so which causes less allergic reaction. And next we have is dupilumab. So it acts on the interleukin 4 and interleukin 13. So these both interleukins we have discussed in the pathogenesis of the asthma. So this is the GINA guideline for asthma management.
So can I just ask a couple of questions here. So one of the questions that came up was that can you, which is a very good question, and I want to address that here before we go on to address some of the types for you guys of treatment. And I want to try to make it simpler so all of you understand. Um, as an adult, say for example, it's reoccurred again after a long period of remission. So, say for example, you had asthma since as a child, you think you outgrew it, the child outgrew it, but hey, all of a sudden, back in the 30s, 40s, asthma came back. Would it be asthma or would it be something else? I want to hear because this is a very, very good question. This happened and it sort of like indirectly happens a lot. So, what you guys think? I hear your views. Asthma coming back. Oh, that as a child, but how on earth does it come back? So, can it come back? Yeah. Fatma is saying it can come back. Dr. Fatma and Sana all saying this is asthma and it's come back. But why has it come back? It went away. It was fine. How on earth did it come back? Let's say I say it's come back after 25 years. Can it come back as after 25 years? It can. So you all are saying it can come back, but we're okay. Let me give one example. Yes, so, and I hear you guys. Mr. Wan also said it can come back. There has to be something that is triggering it. There has to be a stressor that is there, and that is absolutely right. Oas is saying the right thing. There is a trigger. Do you think COVID is a trigger? Is COVID a trigger? COVID is a virus, right? It was a virus attack, coronavirus. And can it trigger? And this is also true. I know someone's from Prime Billing saying, oh, it's family history. Absolutely, we discussed that. There is some history is very important. Triggers is, but and all of you are saying overwhelmingly, COVID can result in asthma. In fact, one of the biggest population we saw after people have had COVID was they could not believe that they were short of breath. And a lot of times they were short of breath months afterwards. And it was actually a variant of their asthma. So asthma was there. They didn't present as wheezing. The other big one they present as was that they were all the time, yes, coughing. It just didn't go away. The cough. And I see this a lot. And I see this now. I'll give you another example. There's friends, people I know, patients I know who travel to, not that I'm saying they travel to India or Sri Lanka or Pakistan, and they travel and they come back and the coughing doesn't go away. They're just saying, oh, it's the cough. So they actually have a subtle underlying, we call it a bronchodilator response or a hyperactive airway. Hyperactive, hyperactive airway. And when they travel, and for whatever reasons, there's different theories why you could have, for example, cold can induce bronchospasm. So um, that's weather related. Exercise can do it because there are some shifts in the temperature. So that is a cause. So there are a lot of causes can result in asthma, but the basic thing is that your airway has to respond to it. Your airway response. Airway is a sensitive, yes, it's a sensitive trachea. I would say, yeah, it could be the lungs as well. You could say that it's the tracheobronchial peripheral airways. So they all are very, very sensitive. So you could say yes, your asthma's come back, and there is a reason for that. There may be some, for example, um, there are some family members, and you ask them in their families, their elders, some of them have and their asthma sort of can flare up. So that can happen. Let me come back to now. I hope that clarifies that, but let me just come back to the treatment part of this thing that I want to try to explain. There is some medications that are used to treat asthma attacks, flare ups, or when the asthma is sensitive. And then there are some medications that prevent the airway from inflaming. Some are preventing the airway from getting inflamed, and some are actually treating the inflammation actively, or the flare up. So you have to, we all have to make a distinction between the two medications. Okay, for example, there is no point in giving a leukotriene receptor antagonist. That medication is to prevent the airway from getting tight. But if it's already tight, which you can know from a peak flow meter, yes, they are preventers, and then there are those medications that reverse is the key. Reverse the airway from getting tight. So I know we're going up. Well, it's 9:30 already. Okay, we're about 40 minutes. We'll take 10 more minutes and then we'll call it the day. So I want you. That's what I want you to remember. Broadly, in kids, you sometimes you have to give them their maintenance daily scheduled doses. That's what I want you to all remember. So in asthma, when we are seeing patients in the clinic, we're making sure that their daily maintenance scheduled medication have the optimum dose. Okay, their dose is the best. They're already having their symptoms under control, and then um, their symptoms are under control, and that we are following them up on a routine basis. But if they are already, their airway is tight, even if it's 5%, 10%, 20%, the maintenance medications help in reversing the airway tightness, and then there are medications that help. So we're going to make some distinction between the two. All right. Okay. So yes, mast cell stabilizers like they prevent them. So if that is the case, you have medications that are there medications that prevent and maintain? Can some of the medication have both effect? They're maintenance medications and are helping, and that's a very, very important question. All right. Are there some medications that do that? Both double action. Only heard one or two. Jana say yes, and okay. So if the common medication that we used to use in the past was albuterol, everyone has probably heard of albuterol. No, singular actually doesn't do that. Is one medication doesn't reverse the ongoing. It's actually a stabilizer, prevents preventive medication. Math, leukotriene isn't. So let me go back to that. I'm going to come back to that in a little second because I do want to put in a few words about the biologics and how that has changed the landscape of asthma medication. So I'm going to discuss it, but just remember there are albuterol, the common known medication that reversed any medication effect, and that is one of the things that Dr. Fatima was going to discuss because the new GINA guidelines have challenged that. Right, there are long-term beta. Correct. Albuterol can be short-term. Medication was your steroid. The maintenance medication we say was the steroid. The preventive medication or bronchodilator was the albuterol or formoterol, their analogs. But there's been a subtle change in the GINA guidelines, which we will discuss later on. I guess it's very, very important because now they're saying you could, if you are having frequent, the important thing is in your mind, make a diagnosis. Is this person's asthma stable or not? So how do you do that? How are you going to calculate, oh, this kid's, oh my God, he's having a lot of attacks, isn't he? So how are you going to make that distinction? How do you make that distinction? That's important. That you know that the asthma is stable or not. Dr. Fatma discussed that a little bit. Yeah.
Yes, sir.
Right. How do you guys know if the asthma is stable or not? How many attacks do you need to have to in a day so you're going to say asthma is not stable? If I have one attack a day, is that stable asthma or not? Let's start with this. One attack a day. Only one attack.
No, sir. Like if it's on daily basis, so
Well,
it's severe.
well, you gave the answer. So I wanted to see what they say, but you're right. I'm having one attack a day. One. Fatma said no, it's not stable. How about I have attack? Oh, now we got everyone agrees. Okay. So if I'm having one attack a day, that asthma is not stable. You have to consider putting me on a maintenance inhaler. All right. That means the daily inhaler. I need it. Don't let your patients. So you should know. How about I have an attack every 72 hours, every third day? Would you put a person on a maintenance inhaler? Now is another good question. An attack, I don't have it for 2-3 days, and then a third day I would have an attack. And I'm saying not stable or yes stable. Yes, I'm shy saying no, no, yes, no, yes. Is it okay? Let me ask a. If now I'm not 2 days. I'm not having any symptoms. Is my asthma stable or now not? But the third day I'm having an attack, an event, and I'm on something. Okay, we agree that we're going to keep asthma is stable or not. Yes means it is stable, or yes means it's not stable. We have a mixed batch. Some are saying it's stable now, and some are saying it's not stable. Aisha is saying, okay, Jareer is saying it's not stable. So give me an idea, when is it stable? That's a tough question. So if you, let's say I'm going to say, no, it's not stable. Give me an idea, when is it stable? Not stable. Okay, I hear you guys. I'm having an attack every third day. It's still not stable. It's not. No, it's not stable. I'm telling you guys. No, no. Okay, that's an interesting one. So now we got the first time we got from Mr. Danish saying it once. You should only have an attack once a month. That's that's the key question, guys. How are you gonna know? Some saying stable if symptoms less than twice a week. That's the key. That's the key. You should not be having attacks all of a sudden. Broadly, you should say, dude, that's not stable. I can break it down and say classic guidelines is twice a week. Um, you should not consider that stable. So that's sort of like every 3.5 days. It's not. And you should not even twice a month at night wake up with a symptom. Night ones are, like I said before, are very, you should raise your eyebrows when someone wakes up at night. With that's what is all that's what the treatment is all about. Okay, that's when you have to reevaluate what is going on. Why is the person having these attacks? It's not stable, contrary to what you guys think. It's not okay having attacks. Oh, he uses puffer. That you do the. Oh, he does it. He's fine. He's fine. He's fine. It's not okay. And then you as a person, layperson, say, hey, has he been checked up? Did he get an X-ray or a CT? Did he get a blood workup? Have we ruled out other causes? Ruled out mimickers? It could be mimicked, right? Have those been ruled out? So if you say, now I've got someone who's trained, or we know it's asthma. We're not discussing the diagnosis because we did that, right, Dr. Fatima? We did that
Yes,
last time.
yes, sir.
That's a separate discussion. But now today's was that you need to know, even if you see someone, is that a stable asthma or not? All right. And then you talk about maintenance, and then we can talk about short acting, quick relievers, and long term relievers. And I don't want to drag this on a little bit, but I want you all to know about this. Now, I just want to put one comment in, and then we'll discuss Dr. Fatima's question. So I want you to be able to answer all of the what are biologics. I know she beautifully put those in. So just in a nutshell, let me try to explain. Generally, these are reserved for patients who are having frequent attacks, despite us putting on maintenance inhalers. If they're still having attacks, we now give an injection which you can take home once a month. Once a month. And what does it do? it essentially curbs all the triggers. It curbs them. It sort of like acts against them. A lot of the triggers. So you have to have an allergic asthma. You can't do it for, oh, I'm having exercise induced, so I'm going to give a biologic. And what do? We give you a kit and you just put it intramuscular a lot of time, not IV, intramuscular in the muscle. And you do it once a month. And the results are amazing. I was actually going to bring one of my patients into this discussion, and I wanted him to discuss. Maybe I'll do it next time. And I want you to think about these biologics. And I'm not sure are they available everywhere, but I know in the States we have them, and a lot of places in Europe. So they are sort of like game changers in stabilizing especially severe asthmatics. And that's what I'm typing here. All right, guys. This is very, very key. And if you guys have any questions, please do let me know if there are any more questions, right? Do type them so we can answer the question. But let's just meanwhile look at Dr. Fatma's quick questions. Dr. Fatma, do you want to just bring up your questions one more time and ask, just go over them quickly? Just put that slide in or put that, type it in.
So I have shared my slide. Is it moving? The assessment questions.
I don't see it on the assessment. Could you, if you want to type it, you could do that. I
Oh,
think she
okay.
did before it came up. And then we could just eyeball it. And if you guys, anyone has any questions, please just let us know now, right? Because some of you are very, very quiet today, right? We're hoping that you all have got you all understand primarily what's. Dr. Fatima's questions were, what are the main causes of asthma? That's one. Okay. How do you diagnose asthma? That is number two. That was covered last time. And the third question was, how do you manage asthma? Okay. How do you manage asthma? That's the third part is the one that we really discussed today. All right. How do you sort of like an overview? It's not really specific management, but just something that you guys are all aware of what to do, right? And how to manage it. I just want to answer one. Anam had one question about what injections are given to patients. Just to remember, biologics are not given when you are having an acute attack. So you don't give them in the hospital. All right? You don't. You give them when the patient is outpatient, not during an asthma exacerbation. We didn't discuss when do you admit a patient in the hospital. We didn't discuss that. When is it as a stage you recognize, oh my God, I've tried this, and this. Now she has to go to the hospital. It's like a bigger trigger. We didn't discuss that today, and we will. Okay, but more so, we discussed a little bit about Dr. Fatima presenting how what are biologics and their different types, and we select depending upon what are the symptoms and we do some blood tests. Do a simple blood test, so you can give them anywhere in the world actually. So that is the important part, and then um, correct when the symptoms are not getting better. Okay, so that's question one. Another question is, if you're having uncomfortable itching, discomfort in the throat, can it be a sign of asthma? If a person wakes up at night because of it, generally itching is not itching in the throat could be due to some other reasons, especially at night. What could it be? Number one, it could be a posterior nasal drip. Sinuses drip at night. That's number one. What else? Reflux can be another one. It's called sinus issues. They can be there. Reflux issues can be at night. Those can mimic a lot of times and wake you up at night and could be a cause. But generally, discomfort on its own is not. However, if it persists and it's been a long time, it does warrant you to look and have an image of it, not an X-ray, but sometimes not an X-ray, but sometimes it's other stuff. Okay, other than something that is there. All right. So I'm just letting you know about that. Um, so that is one question I want to answer. It's not a common practice to use as needed ICS instead of as needed SAPA, despite of being preferred by GINA. That's a very good question, and you can see um, whoever's brought that up. The GINA guidelines have changed in 2020, I think 2020. So there has been slight modifications, and it you're right, it's not a common practice. Generally, if their symptoms are not getting better and they're using the as needed inhaler a lot, I do tell them to use an ICS with it. Very brilliant question. Dr. Fatma was going to bring that up, and we intentionally held it because it was going to confuse us a little bit. But that's a very good question. I've had a few questions about oxygen saturation. Should they be low in an asthma patient? Can oxygen drop? That's a good question. Can oxygen saturations drop? Mushbar. Oh, I see. I see. Yeah, GINA guidelines is that. So, um, so the answer. What about oxygen saturation dropping? Should what about during an exacerbation? Generally, oxygen sat should not drop, right? But what if you become vasoconstricted? Oxygen dropping means a compromise to your body. You should go to the hospital. All right, don't sit home, try to treat it. If your oxygen, that's in a broad nutshell. If you have a pulse ox and your oxygen sat's dropping, you're an asthma patient, you need to seek help. Okay. Yes, that's very brilliant. I know a lot of you are saying it's due to airflow issues, and that's very true. So just remember that that is very relevant. So I'm gonna say correct. It can drop, and it is an emergency, and you need to address those. All right. Any other questions? If not, that thank you very. We're just gonna wrap it up. If oxygen sat should be above 95, ideally it varies. You yes, it can it may or may not be, but you should try to keep them on the higher side. You also have to see if there's an overlap disease with this. All right, so that's what we're gonna. So next week we're gonna discuss another topic. We're gonna post that. You guys have been very fantastic today. I think we've got a very you've done very great here. But we can do we can ask questions there. I've been keep trying to keep an eye on. They're not a lot, but some of the audience like using Facebook, so we'll keep that door open. I just want to go before we leave. I want to thank Jeremy and Dr. Hamza for making this possible. Maya also did a lot of help with this, so a special thanks for them, and they're sort of like a part of our team. Kizzy, Zalika, and other team members who are going to help us. So I want to thank you all, and obviously you all make it. It's very important that we will keep this. It's now there. It's nothing. We're not discussing any patient-related stuff, and it's for the general audience. So if you next time want to bring your friends in, I'll discuss it with our team members what the topic is, so you can come and ask. The basic purpose is have an interactive discussion and try to get some useful points that we can take home. Okay, and then if we need to discuss any other specific topics, we will. And we'll get someone at times to discuss this informally as well. We want to make sure that our audience here, you guys get knowledgeable, and I consider you part of us, meaning in America. We want to try to educate everyone here, and you're part of us, like I said. So thank you very much. Have a good weekend. Okay, Dr. Fatma, thank you very much again.
Thank you, sir.